All right, well, thanks everybody. We're gonna go ahead and get started, jump back in, and now we're gonna focus a little bit more on what this all means for patients. I'm excited to introduce Dr. Lori Williams, who is gonna be leading us off with a presentation. Dr. Williams is an associate professor in the Department of Symptoms Research at the University of Texas MD Anderson Cancer Center and an advanced oncology certified nurse. She's worked in oncology nursing for 39 years, 19 of which were in blood and marrow transplant, and she currently conducts research in the development and instruments of measures symptoms in patients with cancer and the clinical application of routine symptom monitoring to improve outcomes in patients undergoing cancer therapy. Also, it does some work around patients receiving immunotherapy, and she is going to be sharing with us some perspectives about the current research and how telemedicine could impact the IO patient experience.
All right, good morning, and I feel kind of silly because already we're into the third talk maybe, and we're going to hear some common themes that came out in other talks. So I'm going to talk somewhat on the perspectives on the patient experience of telemedicine. And again, from the patient side, it does provide them the chance for long distance contact with their clinicians, particularly for the patients in the rural settings, also patients who lack transportation or who have mobility problems, and where there is a shortage of clinicians, they may be able to access services that otherwise simply would not be available to them, and that may also give them better access to clinical trials when they're in a remote area. So what are some of the uses of telehealth that from the patient perspective? There are patient-reported outcomes, which is what I do for most of the time, and so we'll talk a lot about that. But there also are the wearables that we've already discussed. Education and coaching, health coaching can be done remotely, and we're involved in some of that. And it also can help adherence to therapies in a variety of ways for the patient. So I'm going to talk just a little bit about patient-reported outcomes, actually a lot about patient-reported outcomes. It's an umbrella term for an outcome that is evaluated directly by a patient based on the patient's perception of disease and its treatment without interpretation of the patient's response by a clinician or anyone else. This is basically symptoms. These are the things like pain, fatigue, nausea, peripheral neuropathies that we can only know with the patient telling us. Sometimes we try to guess what they're feeling, but we really don't know unless they tell us. And so it is a direct measure of their experience of the disease and treatments. Commonly used PROs in oncology are things like quality of life, symptom burden, health status. There are functional measures where patients are asked about how they're functioning, treatment adherence, are you taking your medicines, and then, of course, satisfaction with care. Was the experience good for them? So what are some of the methods of patient-reported outcome assessment? Well, the traditional has been paper. The patient walks into the clinic, they're handed a piece of paper, a questionnaire, they fill it out. Occasionally, it will be sent in the mail. They'll bring it with them because they filled it out. But we now have many new technologies. There are automated telephone systems, which we have used now for over 20 years. Newer applications then have been internet questionnaires that they can fill out on a variety of different devices. There are now mobile apps. I think almost everybody in the world who can program is developing their own mobile app to collect PROs. I get probably 6 emails a day from different companies. And then there are also the ways that patients can answer questionnaires by connections through the EHR and patient portals. Some of the features of the mobile apps that I'm seeing anyway that people are bringing to me is there's the scheduled PRO assessments that can be done. There are also real-time patient reports and diaries that can be collected so the patient can sometimes multiple times a day record how they're feeling with a symptom or whatever. They can report other physiologic measures using some of the things that the wearables that Mark showed us that are out there. Again, they can get patient education on mobile apps, either just general education or actually directed to them specifically. Health coaching, reminders to take their medications or to do an assessment, and collecting, when they take their medicine, they can record that. We have done some studies with patients asking them what they think about some of this interaction that they're having digitally. And we have had patients tell us it's very helpful because they need to know just what's going on with me and how well I'm taking the treatment and accepting what's happening with my body and with my life. So they do realize it can be a benefit for them. It's hitting things that might have happened that you want to make sure and remember to tell them. So this is if you're doing the assessments in between when they're not in the clinic, it gives them the chance to report something that maybe once they get into a visit, they would forget to mention. And they say definitely do it weekly at home, especially electronically. How much more often than that they might do it, is sometimes difficult to tell. So the routine remote symptom monitoring and response has actually been shown to improve outcomes. It has, in general, it's been looked at, did it improve quality of life? And yes, it did. Did it improve resource utilization? That was things like, were there as many emergency room visits? Were there as many hospitalizations? Patients on active chemotherapy, particularly advanced cancer patients who've had this monitoring, they had fewer visits to the emergency room, fewer hospitalizations, as was said before. It catches things early. They have had a better ability to continue treatment. And finally, I think the most impressive show of how this can help was Ethan Bash's plenary presentation at ASCO a little over 2 years ago, where he showed it actually improved overall survival significantly out to the 5-year level in patients who were had advanced cancer on standard chemotherapy, probably related to their ability to continue active treatment for a longer period of time. It also facilitates definitely communication between the patient and clinician. There have been several studies that have looked at that. When patients had this routine monitoring, and the clinician has then access to these results, there will be more discussion of these issues in the patient visit. And it enhances the clinician's ability to help the patient manage their symptoms. So in terms of quality of life, this was from Ethan Bash's study. Patients who got usual care versus who got what he called the STAR care, which was this automated system. And it was a fairly large number of patients in this study. There were more of them who reported an improvement in quality of life who got the STAR than the patients who did not. And he measured quality of life using the EQ5D, and it was significant. 63% of these patients, though, reported a severe disabling symptom at least once during the course of this study, which was, I think most of these patients were on about 7 months. So that was interesting that there was such a high percentage of, and these were people getting standard chemotherapy. And 1.7% of the total number of assessments, and this was like, I want to say, between 40 and 60,000 assessments that were done over the course of this, 1.7% of them were in the severe and disabling range. So on the one hand, you pick these up, and on the other hand, as some clinicians are afraid of, the number that you're going to get is not going to just overwhelm you. It's not going to be that every 2 minutes you're getting another assessment that, oh my gosh, I've got to do something about. The most common or severe or disabling symptoms that he found in these patients were fatigue, pain, anorexia, dyspnea, neuropathy, and nausea, which is not unusual. And most frequently, what the patient needed was just some counseling about symptom management. That was 77% of the time. And in a minute, we'll see there are some systems that can actually do that automated. This is the second study that was done by Kathy Mooney at the University of Utah. She is a nurse researcher. And she had patients, these were breast cancer patients who were on active therapy. She had 358 patients. And all patients assessed 11 symptoms daily using an automated phone system. It amazes me that she got them to do it daily, but the patients had a lot of feedback from this. And I think that's one thing that's important when you're doing this with patients. They want to know that somebody's going to look at this. They don't want to do it and it just goes into the cyberspace and nothing happens to it. They would receive automated self-management coaching if they reported a symptom at a level that was preset, that was decided that they could possibly use some help with. And then they actually got a call from a nurse practitioner if, again, on preset guidelines, they considered symptoms poorly managed. So these were either symptoms that were already at a moderate to severe level or symptoms that they got the automated coaching and after 3 days, there was no improvement. It was still staying at the same level. So the patients did get feedback on this, and that I think was one of the important things. The patients in her usual care group just got reminders to call providers if they had a problem. Her most common symptoms were fatigue, pain, trouble sleeping, and nausea. Of the usual care patients, I thought it was interesting that even though they got these reminders, only 5% contacted their physicians. So they, or their providers, they were not calling on their own. 37% of the usual care patients had symptoms at what were the alert levels and only 17% of standard care, which means they were keeping their symptoms better controlled. And 10 of the 11 symptoms were lower for the symptom care at home patients than for the usual care. And you can see that on here, the red symptoms are the usual care and the blue symptoms, the average levels, are the patients who had the symptom care at home. So now, how do we apply this to our new world of immunotherapy? Well, with chemotherapy, it's kind of easy to know how to do this. And I've got just a few slides here that from our work and the work of others that show what the common trajectory of symptoms with our, like for instance, standard chemotherapy is. And we know that there's going to be this big peak right here, maybe 3 days after they've had the chemotherapy. And then they gradually get better until it's almost time for another treatment. So this is where we would target to be especially watchful with these patients to be sure that we're managing the symptoms well. Again, with radiation therapy, we know, and this is some of our work, that they should get radiation for around 6 weeks. And sure enough, right at about 6 weeks is where they start to peak. And then it gradually goes back down. And this was for some radiation-specific symptoms. This was just for more general symptoms. Again, we would start assessing these patients maybe around week 2 to 3 and then keep assessing till they get better. After surgery, we've done a lot of work with symptoms in surgery and particularly in the new rapid recovery after surgery techniques. And again, most of the time these patients, and this is when they're in the hospital, their symptoms are peaking the day after the surgery. They gradually go down. And then here around day 5, when they go home, it goes up again. So again, you're assessing them here in the hospital to be sure you're managing, but then here when they go home for a few days, it's going to be important to check to be sure. But what do we know about immunotherapies? And what, first of all, are we going to measure? Because do we really understand all of the things we should be measuring? And was mentioned in the initial trials, a lot of the endocrine therapies, the side effects were not recognized, and it was only later. So, there are no validated patient-reported outcome measures right now for immunotherapy. They are using them in quite a few trials. They're using PROs now in quite a few immunotherapy trials, partly because the FDA is encouraging it. But most of what they're using are kind of standard quality of life measures and maybe disease specific for the disease, but we don't know specifically. When do we measure? Again, the side effect development with immunotherapies is different. And then who do we measure? Who would be the patients that would be the most important to be doing these measurements with? So what to measure? This is some slides from some of the studies that have been done in immunotherapy, mostly with more like the adverse events. And we know that skin toxicities are some of the most common, followed by GI. And it partly depends too, when you're talking about the checkpoint inhibitors, which ones you're using, and also how many patients are having them. Some of the issues that we have with measuring symptoms is you often want to measure the thing you're going to get the biggest bang for your buck for. So you want to measure the things that are going to be occurring in most patients, and you don't want to measure the things that only occur rarely. However, what we know with immunotherapy is those rare things, while they're rare, when they happen, they're bad. And those are the things that we really need to pick up. For me, measuring symptoms, this is kind of like a new world, because how do we do this? Because it kind of goes against our usual paradigm. So the FDA did review the registration trials of the checkpoint inhibitors, and 75% included PROs. They were mostly health status, quality of life, and then disease. And the FDA, from looking at this, has suggested 8 key symptoms for immunotherapies. That's fatigue, diarrhea, cough, shortness of breath, musculoskeletal pain, rash, pruritus, and fever. Whether this is a complete list, we don't know. When to measure for this, we don't know. But at least I'm glad that we have this, because this at least gives us a starting point of saying, what should we be asking? When do we measure? Well, this is kind of like the medium time to onset of these different side effects of immunotherapies. So for instance, and it looks like in the early stages, there's not much of anything, and then all of a sudden it goes up. So early on in the start of an immunotherapy, maybe we don't want to be measuring very often, but then we've got things that peak all the way from 10 weeks to out to 30 weeks. How often are we going to ask patients to report this? Do we need to think about something different in our paradigms where the patients report to us? But we do know that they don't always do that. But maybe they would do an automated report better than they would do a call. Maybe part of the reason that they don't like to call into the office is because, as most of you know, they call and they usually get a, they may even just get leave a voice message, we'll call you back, or a human being takes the message, but it still will call you back. And then they've got to be tied to their phone until they get the call back. So if we had a method where they could report to us, but again, that involves them, as we talked about workflows, setting up some kind of workflow in the clinic where someone is going to look at that. So there are a lot of issues with this that we need to deal with. Now, who do we measure specifically? Is there a way that maybe, because we do know that many patients on immunotherapies do well, but it's usually patients who do well until they don't do well, and then they don't do well. So who do we measure? And could we set up some kind of system of prioritization where we say, these are the patients that really, really should get measured, and they need to get measured really frequently, and then there are others that maybe less frequently, whatever. We do know that patients with autoimmune disease are often more prone to toxicities with the immunotherapies, but sometimes they're the ones that don't then even get an immunotherapy. Patients with poor renal function, the patients who are receiving the CTLA-4 inhibitors, those cause more side effects. Patients with cardiac disease, sometimes particularly if they're getting a drug that would put them at risk for cardiac disease. But then what else? We don't know. So what now do we need? What do we need to look at? This is kind of where I'm living my life right now. We need the patient perspectives on the immunotherapy side effects. And I have several studies ongoing where I do a lot of qualitative interviewing with patients to find out what their experience of the therapy has been. And so we're doing interviews with patients who are getting several of the checkpoint inhibitors with quite a few different diseases. We're doing interviews with CAR T patients who are undergoing CAR T therapy. What we're trying to find out from them is not just what they're experiencing, but right before the side effect happened, what did they feel like? Was there any early thing that they can look back and say, you know, I noticed that day that I was just maybe a little more tired than usual. I was having a little nausea or this, whatever. And then, you know, my skin just was a little itchy, but there really wasn't anything there. And then the next day when I woke up, you know, I was, you know, had this or that or the other thing. With the CAR T too, we're very interested in, are there some of the early signs of the neurologic toxicities that they get? We need to figure out what these risk factors are for the development so we can better target where we want to when we want to be having these patients give us information about what's going on. Are there predictors or precursors? We need a better understanding then of the trajectories of these. And finally, novel approaches to the immunoside effect measurement. I think particularly with some of these, we're going to need combination measures. For instance, the lung toxicities. Having worked in stem cell transplant and dealt with patients with allogeneic transplants who then were getting bronchiolitis obliterans and things like that, there frequently would be these subtle shortness of breath symptoms. And then if you check their O2 sats, their pulse ox, it would be declining. And so there certainly, I think, are opportunities to be measuring patients at home with both asking them how they're feeling, and then if they're having a certain symptom, even just at a very low level, asking them to do something like check their O2 sat or their heart rate or whatever. So that kind of finishes my remarks, and I hope that leaves us a little time then to have some discussions, and I'm happy to answer any questions about the work we've done and how we've done it.
Again, another great discussion, and the more I learn, the more I realize I have no idea what I'm doing. So it's always good to hear some of the discussions which are really patient-centric. We often kind of get lost in data, in the analytics, and also even the evolution of outcomes. But when it comes back to the patient, which, I mean, Laura, what you're doing is absolutely incredible. It's so well conceived, well contrived in an area where we're still learning in immunotherapy. But the one thing I wanted to bring up, which is something you kind of alluded to, but also the unawareness or the lack of knowledge, was side effects. And with immuno-oncology, we know there's the CTLA-4s, which I think if you showed that slide back with the side effect emergence, where Jeff Weber actually showed it. What was very interesting was this data actually is derived from CTLA-4 developments, right? So really, it's not the PD1. It's just, this is PD. You know, we have PD1s, we have PDL1s, we have a few other wackadoodle ones coming out too. But with regards to CTLA-4, this is the most well-defined side effect profile. Now, with the emergence of immuno-oncology, what we're finding is we're switching doses of CTLA-4 to make it more amenable to the patient, to lower side effects and improve tolerability and also adherence to the current dosing. So I think that the question I have is, when you're looking at your studies, you're looking at the combination of monotherapy or even differences between a PD-1 and a PDL-1, and in some cases with RCC now, renal cell cancer, we have utilization of combo IV and oral, so immunotherapy plus a TKI. So right there, the diarrhea side effects, because we know orals have about 50% diarrhea, and IPI and also Nivo have, you know, it's pretty high too. So in regards to this, what are side effects that you are seeing which you think will help address first the patient in terms of adherence, you know, from your discussions, and two, are you seeing a difference in dosages or therapies that may actually be more disease and drug specific than you normally thought from this broad width of immuno-oncology? So it's a very long-winded question, I guess. I feel like it's almost like Rodney Dangerfield and going back to school. I have one question with 47 different sub-questions, I guess, so I'll kind of leave it at that.
Yeah, well, and again, we don't have a lot of data yet. We have some. And I think one of the GI toxicities in general are one of the things that I think, particularly when you're talking about the oral medications, that and fatigue, that will cause the patients to cut back or not take their drugs all the time. The diarrhea and the nausea and vomiting, depending on how severe it is. And I did a lot of work with TKIs before there was immunotherapy. And those were the GI toxicities were the ones where the patient would start taking the drug, and then if they'd start having it, they may just stop the drug and say, I can't deal with this. Other patients would rearrange their lives so that they could deal with it, because there are some of the TKIs, as I'm sure you're aware, where they can take their pill and they know that 30, 45 minutes later, they're going to need a bathroom. But once that's over for the morning, then they would feel safer doing stuff later in the day. So they will rearrange their day for it. The fatigue tended to be, we would see patients more do things like, well, I've got a big event coming up this weekend, so I'll stop taking my treatments for my pills for the weekend so that I've got more energy, you know, so they'd know maybe if they took their last pill on Wednesday, by the weekend they'd be okay. And then once their, you know, family reunion, wedding, whatever it was over, they'd start the next week with the pills again. So those are some of the things, and I think that's absolutely true. I don't know. We have not followed a lot the dosages and the different dosages that have been given. So there may be some of the clinicians here who could speak better to that, but that's definitely something that we will probably take a look at. And we do have patients who have been getting single agents combinations. We have patients now that are getting immunotherapy combined with standard chemotherapy, immunotherapy with radiation. So we're seeing all kinds of different variations with that, and what that's going to cause and what that is going to do to the side effects. I particularly am concerned about some of the lung patients that we're seeing now where they're combining the immunotherapies with lung radiation. That worries me with the pulmonary side effects and things like that. So if any of the other clinicians want to make comments about doses, that would probably be really helpful.
So it's a great presentation. I think I'm struggling a little bit to see what segments of the population's telehealth is the solution. Because as I heard you speaking, You can segment patients. I think identifying high-risk patients is critical. Partly full dose CTLA-4 is one issue, but that's kind of going away except in very, very specific circumstances like melanoma. We do have some combination therapy, so there's, to some extent, there's that initial phase. So part of it is the phase of treatment, part of it is the toxicity of the treatment and expected, and part of it is the long-term consequences. And I'm not sure that the long-term, we go to the end, is that for patients who are on checkpoint inhibitors routinely, I don't think telehealth is the answer. I think the answer is they're coming in every 2, 3, or 4 weeks. So a comprehensive assessment when they come in, and to your point, I think it's not about, you know, finding that rare symptom. It's just not, I don't see it happening over months to years actually productively picking those up, but maybe an educational program so that you alert. You talked a lot about that premonition that something's happening, or the first part, and you're not going to capture that on a weekly or monthly. So it's got to be patient derived, I think, for that. Now at the front end, when you get, and now the vast majority of lung cancer patients are getting standard chemo plus IO, and they have more toxicity in that first region, or they get stage 3 or getting radiation plus IO. They don't necessarily miss doses, and they're not getting an oral therapy, but they're at enhanced toxicity. So more intensive management with an EPRO tool at the beginning, more education around the patient experience once they're on maintenance therapy, to me makes sense.
Lori, I've got a question. Is there any kind of national clearinghouse of information about the comorbidities and other effects of IO and other kinds of treatments that is consolidating this information so that we might better target these methodologies, whether it's telemedicine or telehealth or other things like education? Does that exist?
I am not aware of anything. There are registries that different people are doing. And I found that review that the FDA had done where they pulled together a lot of data and then made that recommendation. That was very helpful. We have a couple of big registries at MD Anderson where we're following, but it's not in combination. And we're not, right now, we don't have anybody else doing it with us. It's just our patients. So
Real world data sets coming out now. So we have meta-analyses on the clinical trials, including of toxicity. What we really need, though, is real world evidence on the patients that are being treated in the community, which are very different than the ones that were on trials.
Yes.
Right.
mhm.
Yeah, that was my comment too, you know, relying on a trial patient population will mislead us because those are not patients with type 1 diabetes who are being treated with ipilimumab-based treatment, et cetera, you know. What I found interesting, actually, maybe even to Lee's point, you know, I actually think it's harder for us to push that back to the patient because we don't know when and what and who to measure, right? The very points that you lined out so beautifully, you know. So having some sort of telehealth mechanism for these patients to have really a very quick access to a clinician may actually really be a clue to that, so we don't have so many patients fall through the cracks when their problem is at a grade 1 and very fixable rather than showing up with a grade 4 in the ER. And that's typically the modus operandi that I see my patients do, you know, it's not bad enough, and it's hard to get my physician, I'm not gonna call. And then it's a little worse the next day and they still have the same arguments, well, maybe it'll get better by the next day, and then by day 4 they're in the ER because they can't breathe. So you know, I think you're touching on a very important thing because ultimately very much because it is so different than a chemotherapy population where you know exactly who to test at what time for what, because it's such a predictable side effect profile. Everybody performs the same, you know exactly when they're going to lose their hair, when their nadir is going to be, etc. Right? Immunotherapy is so different. And even if you were able to identify your high-risk patient population, well, they're just at a higher risk of developing the problem. That doesn't mean that the person that doesn't have high risk won't have it. So you don't have the luxury of not monitoring them, you know. So you need a very broad net. And as Lee said earlier, we don't have enough clinicians to have that broad net over this ever-evolving field of immuno-oncology. And I predict in 10 years, every disease will have an immunotherapy for it. So we're gonna have to find a way to screen everybody on a daily basis for things that we don't even know they could have, right? And so maybe telemedicine is ultimately the way to do that, yeah.
And I think the Kathy Mooney's study where she used the nurse practitioner, if you, and I know a lot of people are setting up now triage clinics that are nurse run. Sometimes they're run by an APP and sometimes they're just run by a clinic nurse who has algorithms, and she had algorithms in her study that were well defined, that were based on evidence-based guidelines. And so I think that may be somewhat the way to go. And I think then if we do a good job of education with the patients, and I think, again, as I said, if patients know that someone is going to look at what they've reported and is going to get back to them, and that we do it in a fairly timely manner, I don't even know that it's a great thing if they report first thing in the morning and they don't get a call back or a response back till 5 in the evening. I think it probably needs to be a little quicker than that, but I absolutely agree with you. We see that all the time where the patient, the first day, it's not bad, and they think maybe it'll go away, and they don't report the second, third, and then they end up in the ER. And that's why I think with our more standard therapies, the routine monitoring has been so effective, because we know when to. With immunotherapy, we don't, and that's what I really think we need to think outside the box, and how are we going to do it. And the other thing, and I didn't mention this and I should have before, it's really important that whatever we're measuring with is something that provides the clinician with clinically actionable data. A lot of the quality of life measures just give you a score for emotional function, physical function, and that's not that helpful. Symptoms are more specific and therefore are more actionable, and functions, how a patient is functioning. If they can't walk, that's a little easier to handle.
To what extent do you think any of the symptom monitoring can be automated?
We do a lot of automated.
Can you just say a little bit more about how that's done?
For years, we have used phone. And then we went to internet-based, where the patient can do it on their computer, on a tablet, on a phone. We find still that, which surprised us a lot, that the patients who we asked about what they thought about this, if they said they were really sick, they would rather get a phone call. They felt that was easier, and especially if they could, it would ask them your symptom and give me, your symptom 0 to 10, pain, nausea, diarrhea, whatever, shortness of breath, and they could just say a number. That was the easiest. So although that seems to be the least high tech, sometimes that may be the best for a patient. But it would be an automated system where, so you have to have, at that point, I think you have to have, your questions have to be fairly simple and fairly easily answered. And patient can't have to keep in their mind 4 or 5 different response options. So sometimes maybe just a number is better than, all the way from not at all to a little bit to, that's hard to remember. So it's got to be something fairly easy. And then the patient just responds, and there are alert systems within the software so that the clinician, whoever is supposed to respond, gets it just like you would with labs. So, you have your patient have a CBC done, and if they're absolute granulocyte count is like 300, you all of a sudden are going to get an alert saying you've got a patient, or their hemoglobin is 6.7, you're going to get an alert saying you've got a patient that needs to be seen. If it's within normal limits, or so with symptoms at a lower level, you don't get anything. And then as some of these systems have done, if it's there, but it's a low level, the patient can even just get an automated, we noticed you're having a little nausea today. Have you taken your nausea medication? Do you have any nausea medicine. I mean, find out, the system can kind of go back and forth with the patient to get some information. And then if there is an issue, so say like it's a patient who reports a nausea of 3, and then the system says, if you take your nausea medicine, no, why haven't you taken it? I ran out. Then an alert can go to the clinic, to somebody in the clinic saying, reorder nausea medication for. So does that answer your question? So yes, so it can be done automated so that you don't get bothered with, it's there available for you to see if you want to go and look at it, but you're not going to get the alert. So it'd be like labs.
Building on that a little bit, you mentioned you're getting 6 or 7 emails a day with people with new mobile health approaches for PROs. Can you talk a little bit about like what are they missing, or what would you like to see versus not, because you're seeing so many?
Probably the biggest issue that I have with them, and because some of them are very nice systems, very sophisticated, some of them less so, but we use Epic. None of them right now interface well with Epic. And when you're particularly, and we work with patient-reported outcomes from both a research perspective and a clinical care perspective. When we're working from a research perspective, we want it into a usable database, and we want it secure so that there's no worry with HIPAA violations and our IRB doesn't come down on us and all that kind of stuff. But that's all we need. But when we're doing it for clinical care, you really want it to get into the electronic medical record right away. And so that's probably number one. And I realize it's not just the person who's developing the app. It's not their problem. It's also, at least from my perspective, having dealt with this now for quite a few years, it's partly an Epic problem too. So that's number one. We do send out for clinical care to patients through MyChart, the questionnaires, because that's how our institution feels safest from a confidentiality perspective. I think MyChart has its own problems. Being someone who also has to use MyChart for for my own care. There are lots of things about MyChart that I find extremely annoying. So that would be the one thing I would want. The second one is they need to be really flexible in terms of putting the questionnaire in. And some of them are, and some of them are, what you do is you can put in the question and then it's just going to give you a vertical list of options. Well, when you're dealing with patient-reported outcomes and validated questionnaires, what they see on the screen has got to look like what we developed on paper. And so, and often also for patients, vertical, at least in our society and the way we read and everything, vertical is almost harder to manage than horizontal. So that's the second thing. And it's got to be something, if it's an app and they're going to use it on their phone, and these are patients and often older people, it's got to be big enough that they can see it. And then it's also got to be easy for them to respond. And a lot of our patients have peripheral neuropathy. So if you've got, like little close things, or we have app developers who bring us apps and they've got a sliding thing that looks really cool, but for someone with peripheral neuropathy, that's kind of a no starter. So, and then it's also really nice if you can build in then these education things where it will just automatically, you can set it so that you can push education to the patient based on what they've responded. And it's got to have alerts. I mean, it's got to have the alert system so that you can tell the clinician what happened. So those are the things that I think, and ideally, the system will also have whatever the clinician was seeing, it would have decision support also, so that there would not only would there be education that would come up for the patient, but when you got an alert, it would show the clinician, an algorithm if they wanted that they could follow for dealing with that symptom. So.
Can I ask you a question about how you would like to see quality of life measured? And I think this is important for IO patients who frequently are on therapies for a long time, and we have this undefined fatigue. But how would you like to see it? We have the clinical trial surveys, which are really designed to give us the most information in the smallest number of it's a construct, right? It's not really for day-to-day use. So how do you think we should measure quality of life long-term in these patients?
I mean, I think when you want to do it in a trial perspective, you're going to have some kind of a questionnaire. I think sometimes when we're talking about quality of life, which is a much broader concept than what you might want to respond to on a day-to-day clinical basis, but what you want to, and it's two different pieces of information that you want to know. One thing you want to know is, I've got this patient here right now, do I need to do anything for them? The other thing you want to know is, I've got them on this long-term immunotherapy, which I think is a really important issue, because I think we are going to see patients on long-term immunotherapies. I've done a lot of work with CML where those patients are on long-term, and the vast majority of those patients do very well. You've got a subset that doesn't do very well. But you're talking about then, giving them the choice between their cancer coming back, but maybe, they're not going to have the side effects of the drug, or the side effects of the drug. And so how is that affecting their quality of life? And what does that mean to them? And so I think that we need to remember not to measure quality of life, first of all, too often. It's not something that you want to ask somebody to report weekly. I think monthly, other than for patients maybe in acute treatment, just to know kind of what happens, their quality of life from month to month. But for the long term, maybe every 6 months is enough to measure that quality of life. I think it's really important to talk to some patients who are on that therapy long term, to find out from them, first of all, what is it that has changed about your life since you've been on this therapy, and what would you like? What are you experiencing, and what are the things that you can handle, and what are the things you can't handle? And then be sure that those are the things that we're asking when we ask quality of life, so that we understand the patient perspective. And I've got to give a lot of credit to the FDA, because I think it's been primarily from the regulations that they have brought out in the last, since 2005, they've issued their first guidance on doing patient-reported outcomes in drug trials, and they started insisting that we speak to patients and ask them. So those are my thoughts. And I think if you're only going to ask them every 6 months, that gives you the freedom to ask maybe a few more questions. And in our talking to patients, because we did one study where we gave patients a couple of quality of life questionnaires, and then we gave them a symptom questionnaire, and we asked them what they thought about all of the questionnaires and the differences and stuff. They did think it was very important for their clinicians and providers to get the information from the quality of life, but they just didn't think that it was important to do it really frequently. Yeah.
Lori, does the PHQ-9 play a role in this at all, in these assessments?
We have used it sometimes, but it's not one of our
go-to tools.
Yeah.
We have to measure that all the time now for OCN.
Mm-hmm.
Yes. Yes, right. And I think that's part of this development and evolving of understanding the role of patient-reported outcomes in patient care, becoming more patient-centered. I think sometimes at this point, we don't necessarily always pick the right measures at the right time. Still, I know the stuff for the CAR-T, there's been the draft guidance on what should be done, and then they ended up mentioning, I think they only mentioned 2 in the draft, and they've got maybe 7 in the new that are possibilities, but nobody knows, and there's not any that are specific anyway.
So, going on to this discussion, Lori, I was going to actually, you already asked half my questions, so I was going to kind of relate both you and Sarah here, and like kind of pivot off each other. But, when we're looking at this, we're looking at value-based care models, and we're talking about tele-oncology or telehealth in this type of fashion. Is there any data which can support preventative-based measures? And what I mean by that is, you talk to a patient, the patient refers, I kind of feel a little bit off, right? I feel a little bit tired. I don't have my same thought process, and I'm doing more of an acute type of scenario where the patient may have hypothetically an outpatient CAR T, right, for one of the types of CAR T currently available in the market, based on the patient selection. Sarah calls up the patient, and you may have a certain kind of checklist which she follows up on every day because the patient may have come in the clinic, patient goes home, there may be a follow-up call as well. Are there certain acute measures which have been seen by what you've kind of done already, and again, maybe a very small subset of this population who are receiving IO, that you can say, based on what we're doing, we are actually preventing hospitalizations, increased ambulatory care, as well as a few other pieces as well, which prevents them from going inpatient based on your current study at all. And I think, with value-based care models, we're seeing this discussion of keeping them out, really coming from the at-home model initially, and now going to the OCM and maybe the OCF, right? And kind of seeing how that kind of works out to prevent certain admissions, but also maximize outpatient-based care models.
Yeah, I don't have anything for immunotherapy yet. We're too early because, like I said, we don't quite still know what all to measure. We have several times put together a list of symptoms that the clinicians thought, and we've been asking those. And usually when we do that, we find that probably 70% to 80% were not the right thing to ask us. We're just getting poor response. The results are just, but there'll be a few. And again, these are hard to do. This is like getting a label indication from a symptom for a drug, which there have been. Jakafi was the big, but we did do a study several years ago with radiation therapy and looking at pulmonary fibrosis post-radiation long-term. And we did identify 2 symptoms that if they started to occur, it was bring the patient back in, cough and shortness of breath, bring the patient back in right now. So be measuring that on a fairly regular basis in these patients. And if you get them in and start them on some steroid therapy or something to stop that inflammatory process that's causing that, you can make a difference in their final outcomes. So that's what I would hope we would be able to eventually get to in immunotherapy, but it's just, you need data for that. And you have 1 or 2 or 3 patients where you see something and you catch it, and that's great. And, I know when that happens to us, then that's how we treat everybody. But we don't have the hard data to say, yes, that ought to be standard of care.
One thing anecdotally I can say from treating both inpatient and outpatient CAR T patients is we've noticed we're kind of getting rid of that confounding factor of doing a neurologic check at 4 a.m. and not really knowing, is this a change or is it we're waking you up at 4 a.m. and asking you a ridiculous amount of questions? Because a lot of times with our inpatient CAR T therapy patients, we kind of get into this muddied water of, well, I'm not really sure. I just woke up a 79-year-old at 4 a.m. and asked them this long laundry list of things and asked them to sign their name and write a sentence. And I wouldn't do a good job at that at 4 a.m. So with our outpatient patients, we're only doing that check once at 10 p.m. before they go to sleep. And we've noticed, granted, it's typically a different drug and there's a different toxicity profile for the different drugs, but we've kind of been able to get rid of that confounding factor because we're catching them before they go to bed. They haven't been sleeping for 3 hours and they're not being woken up every 3 hours for vitals or labs or anything like that. So when we see a change, we're more able to say, okay, this is a real change. We do a very extensive neurologic exam via telemedicine. So, we make them draw a clock and we pick a time and we make them do all of those things. So we're able to see a true change when we're checking less frequently, when we're checking every 4 hours, waking them up all the time, the beeping of the hospital, no one gets good sleep in the hospital. We have noticed that, the true changes we're seeing are really true changes. And that's been a big help from the telemedicine part of that and keeping the patient outpatient. We've only had to we have a very small number that we've done so far, but we've been able to keep most of them outpatient for the duration of their therapy because of that. So I think it's, in a weird way, almost like less data points lets us really truly see the real changes instead of deciding, oh shoot, this might be a change. And then we're having to kind of play guesswork in there, so.
Yeah, that's a really important point, just you have to know when to measure, because too much can be just as bad as too little.